Today we'll talk about the aortic aneurysm. So for the diagnosis of aortic aneurysm, imaging is very important. The role of imaging in chronic aneurysm is to establish, monitor the size of aneurysm and define the anatomy and comorbidity. CT is most widely used modality, but MRI is useful as well. And there is also a role of echocardiography and angiography. CT is widely available and the images are familiar to the clinicians. The CT provide accurate and reproducible information from anatomy, size, and extent of the disease. So it is used for 6-monthly assessment of the chronic aneurysm, and these must be standardized assessment and estimate the aneurysm size and can vary widely between these scans and within a single test depending on whether the measurement was taken and how perpendicular and measure was to the wall of the aorta. The CT angiography provides additional information about the intramural hematoma, thrombosis, and dissection. A detailed 3D reconstruction can be used to help the operative planning. The abdominal aorta is always imaged as 25% of the patients with thoracic aneurysm also have abdominal aortic aneurysm. The CT angiography can be performed to image the coronary and carotid anatomy to identify the lesion. In the patient with renal insufficiency, it is important to ensure the adequate hydration and avoid nephrotoxic drugs in days before and after the contrast. MRI scanners are less widely available for the CT scanners, and they have accurate and reproducible information about the size, anatomy, and extent of the disease. In the transverse, coronal, sagittal, as well as the dynamic images can pinpoint the intimal tears, assess flow in true and false lumens of the dissected aneurysm, and differentiate between the peri-aortic hematoma and thrombosed false aneurysm, and assess LV function and peripheral vascular lesion. Contraindications to MRI include permanent and temporary pacemakers, ICD, intracranial aneurysm, and AVM clips, infusion pumps, cochlear implants, and metal fragments. Aortography is not used that much, but it provides accurate information of the location of the aneurysm in relation to the major branches of the aorta, including the carotid arteries, as well as delineating the pattern of the blood flow within the aorta and the false lumen and to the viscera. The information about the aortic regurgitation can be gained as well as LV function. Coronary angiograms can be carried out as useful adjunct in population at risk in the coronary artery disease. Annulo-aortic ectasia appears to be pear-shaped dilation of the aortic sinuses tapering towards the normal aorta, and the main disadvantage of the aortography is that it does not give any information beyond the lumen of the aorta and may underestimate the size of the aneurysm where there is intramural thrombus. The aortography has 84% sensitivity in diagnosing type B dissection, and it is also nephrotoxic. Aortography is invasive procedure and may be difficult to carry out in patients with severe peripheral vascular disease. Other investigations which are important is ECG and transthoracic echo. Mitral valve disease frequently accompanies aortic aneurysm and Marfan's disease. Coronary angiography for the male patient over 35 and female over 45 with the history suggestive of ischemic heart disease, and the patient undergoing repair of ascending aneurysm have concomitant coronary artery disease. Chest X-ray is very important, and to assess lung function, we can perform the lung function studies in COPD patient, spirometry, ABG, and if needed, we can manage the respiratory condition. Renal condition can be managed by GFR. Thoracic aortic aneurysm have 5-year survival of about 40% compared to 20% of thoracoabdominal and abdominal aneurysm. The 5-year survival of the chronic dissecting aneurysm may be as low as 13%. The thoracic aneurysm increases the size about 0.4 centimeter per year, and the arch aneurysm increasing fastest. The larger aneurysm more than 6 centimeter expand the faster rate than the smaller aneurysm, and predicts by law of Laplace. Aneurysm greater than 8 centimeter in diameter increases up to 0.16 centimeters per year, and this size of aneurysm at presentation is most important predictor of the risk of rupture. The annual risk of rupture in the aneurysm between 6 to 6.9 is fourfold that of aneurysm in 4 to 4.9. The median size of the rupture of dissection of ascending aneurysm is 5.9 and 6.9 for descending aneurysm. Once the symptoms develop, the mean time of rupture is about 2 years. The annual risk for rupture of dissection or death is 5 to 6% for the aneurysm, 5 to 5.9 centimeters, and 10 to 15 in aneurysm of more than 6 centimeters. The elective operative mortality is 1.5% for elective repair of ascending aneurysm and 85% for 5-year survival of the aortic root replacement, and the as low as 1% centers, but national mortality is closer to 7%. 5 to 10% of the repair of the arch aneurysm is 75%, and 5 to 10% repair of descending aneurysm with 60% 5-year survival, and 5 to 10% repair of thoracoabdominal aneurysm with 60% 5-year survival. Mode of death in thoracic aneurysm is rupture, dissection, cerebral embolism, and visceral embolism. Indications of surgery for the ascending aorta, it is acute dissection, symptomatic aneurysm, asymptomatic aneurysm more than 5.5, aneurysm of more than 5 with known connective tissue disorder, aneurysm of 5 cm with bicuspid aortic valve, and moderate to severe aortic regurgitation. For the aortic arch, one has to be symptomatic, and descending aorta symptomatic more than 6.5. Contraindications to surgery include advanced age, incurable malignancy, and irreversible profound brain injury. Controversies include borderline aorta and a root replacement or interposition graft with aortic valve replacement. The decision as to whether to replace the coronary sinuses boils down to the balance between the incremental operative mortality of the complete root replacement compared to AVR plus interposition graft, and the long-term risk of disconnection of aneurysm formation and the residual native tissue in the older patient without an obvious connective tissue disorder. So for surgery of the ascending aneurysm, the aim is to resect all the aneurysmal aorta, anastomosing the tube graft to the relatively normal aorta, and depending on the segments of the proximal ascending aorta are affected, and this may involve a simple interpositional graft, replacement of the aortic valve, and replacement and remodeling of the aortic root. If the aneurysm is quite proximal, it may be possible to perform a distal anastomosis with the cross clamp on. More distal involvement requires the removal of the cross clamp to do the hemiarch replacement under 5 to 20 minutes of hypothermic arrest. Sternotomy, axillary femoral, and low aortic cannulation. The site will be excised with the aneurysmal segment and deep hypothermic circulatory arrest. The high aortic cannulation only is its intention is to leave the distal ascending aorta in place and perform the anastomosis. When performing the interpositional graft, this involves the replacement of the aneurysmal aorta with the tube graft, and the aortic valve may or may not be replaced, and the sinuses are preserved, and so there is no need to reimplant the coronaries. And it is usually possible to perform without the circulatory arrest, and the technique is very well described. It is suitable for the aneurysm limited to the ascending aorta and not involving the aortic root. And in young patients with dilated sinus, or in the patient where there is evidence of chronic dissection or other primary abscess formation involving the sinus, annulus, and root involvement is required. In elderly patient with moderate sinus dilation, and interposition graft is usually a better option than a root replacement, and as the risk of complication from leaving the sinuses intact is probably lower. In acute type A dissection, it is preferable to perform the interposition graft, even if there is some evidence of dissection into the sinuses, as the root replacement in this setting is much more difficult. Dissected sinuses can be reapproximated by bioglutathione strip running 4-0-Fluorine prior to performing the proximal interposition anastomosis. Root replacement is indicated when the ascending aortic aneurysm involves the aortic root, and severe valvular disease means that this is not possible to preserve the aortic valve. Uh, in the aortic root surgery, cabral graft is a useful aortic root replacement where the coronary buttons are too friable, adhesed or calcified or fibrous to permit the mobilization enough for them to be anastomosed to the aortic conduit without tension. It is particularly useful as adjunct in reoperative aortic root replacement if the original aortic conduit has to be excised. A length of SVG, saphenous vein graft, or a Dacron graft is sewn end to end to the left coronary buttons using the 6-prolene and can be wrapped around the graft so that it can be sewn end to side to the right coronary button. Caprol and patch shunt can be used in the case of right coronary ischemia or right coronary button is more frequently the source of the problem than compromise the separation from the bypass than the left button, possibly because it is more prone to distortion and kinking as the heart fills. For valve sparing surgery, it is important that aortic root pathology necessitating the surgical correction frequently coexists the structural and normal aortic valve leaflet. Any technique that allows the root reconstruction without valve replacement avoids some of the disadvantages of the aortic root replacement. A large number of valve sparing root techniques have involved and which can be divided into two main groups: remodeling techniques and the reimplantation technique. The valve sparing surgery is remodeling by Yakub, and this technique is supposedly technically easier than David and most useful in in a smaller root. The reimplantation technique by David is also a very widespread. For the arch replacement, the aneurysms and type A dissections may involve a distal ascending aortic arch, and the main options for the arch replacement is island technique and trifurcated graft. Trifurcated graft, which has largely superseded the island technique, and a stage 1 elephant trunk. So, when the patient is ready for the surgery, we dissect the phrenic and vagus nerve and select and trim the trifurcation graft to set the sizes of two distal limbs, usually 8 and 10 millimeter graft, have the additional side at the lateral cannulation. Pump is stopped and the cross clamp is removed and the blood vented from the arch, and the dissection of the flap or aneurysmal portion does not extend into the arch or anastomosis with the distal ascending aorta can be carried out, and if the dissection flap or aneurysmal portion extend into the arch but does not extend to the descending aorta or the vessel, the aorta is transected obliquely and anastomosis is fashioned similarly. If the pathology involves the whole arch, then it must be replaced with the arch vessels reimplanted and trifurcated graft technique is used. Transected aorta and distal arch origin on the left subclavian and the head and neck vessels close to their origin using a continuous fluoroproline and SH stitch is starting forehand well to the left heel inside out the Dacron graft and onto the native vessel. If the axillary cannulation was used, the pump is then resumed at 50 ml per minute after completion of graft. A Dacron graft is selected to fit the distal anastomosis using a Teflon to the buttress. The the aim of the surgery of the descending aneurysm is to resect the aneurysmal aorta, reimplant the larger radicular arteries, and all involve the visceral arteries. If the arch is not involved, circulatory arrest is not required, and it may be possible to use the partial left heart bypass instead of the full cardiopulmonary bypass. And the variable extent of thoracoabdominal aneurysm makes the accurate preoperative imaging vital. The spinal protection is an important part of the surgery of the descending aorta, as the blood supply to the spinal cord is usually compromised, resulting in paraplegia rates higher than 20%. The technique of the spinal protection include the surgical spinal fluid withdrawal, hypothermia, and pharmacological adjunct. So, during the surgery, one has to deflate the lung, diaphragm is divided, retroperitoneum is divided lateral to the colon, develop a plane anterior to psoas, retract the descending colon, divide the crux of diaphragm, and the entire approach can be retroperitoneal, particularly where extensive adhesions are formed from the previous laparotomies. Options include cardiopulmonary bypass, clamp and go. The cardiopulmonary bypass is not used and the patient is not cooled, and there is no control of the upper body hypertension on clamping the descending aorta. Full cardiopulmonary bypass with deep hypothermic circulatory arrest can be performed using the FEM-FEM cannulation, FEM bypass augmented or axial femoral bypass, and arterial drainage from left subclavian or distal aorta, and the cardiopulmonary bypass is instituted. Partial left heart bypass is also an option. It reduces the risk of stroke and aortic cannulation, and reduces the risk of aortic dissection, and reduces pulmonary dysfunction post-operatively. And some surgeons give a reduced dose of heparin. Traumatic aortic transection is caused by massive deceleration injuries, and the force needed to rupture the aorta is equivalent to intraluminal pressure, that is 2000 millimeters of mercury. High speed impact result in continued forward movement in the distal end of the aortic arch. When the transection is complete, death is almost instantaneous and there is no tissue or tamponade hemorrhage. The tears spare the adventitia or pleura, resulting in the proportionate small hemorrhages into the retroperitoneal tissue that result in severe chest pain radiating through back hemorrhagic shock and hemithoraces. Diagnose the classical features: widened mediastinum. Features that look include the rightward shift of the trachea, blurring of the sharp outline of the proximal descending aorta, opacification of the aortopulmonary window, and aortography can be helpful along with MRI and CT scan. Surgery is indicated if this patient is stable with contained aortic injury who do not require laparotomy, craniotomy, pelvic stabilization, thoracotomy for bleeding. Emergency repair is also indicated for signs of impending rupture, hemithorax, contained hematoma. Outcome, the operative mortality is 40% and overall hospital mortality is 30%. And when operating, there should be dissection around the isthmus, usually location of the tear, clamp and go when the aorta is simply cross-clamped. Endoluminal stenting is increasingly used instead of surgery for traumatic aortic rupture. It appears to offer a similar short-term survival without the need for thoracotomy, single lung ventilation, or cardiopulmonary bypass. GOTEC R grafts are used to convey relatively short segments, and there's a little data available on the outcomes. Hope you have enjoyed this video. If you want any additional information, then please let me know. We can make a further video, and just write down in the comments. Thank you very much.